Thank you, Dr. Gazette, and thank you, distinguished panelists and audience members, and thank you to the sponsor for organizing this symposium. So I'm a heart failure cardiologist in Atlanta. My name's Dr. Brian Howard, and I'm going to spend a few moments talking about the data and the results behind the BeAT-HF trial. Here are my disclosures. So I'll start off by discussing the results of the pre-market phase of the BeAT-HF trial, which led to FDA approval, and I'll frame these results in the construct of the post-market phase, which were recently presented at THT by Dr. Michael Zeil. I'm also going to spend some time talking about the win ratio analysis and how it applies specifically to the outcomes described in the BeAT-HF trial. So BeAT-HF was a prospective, multi-center, randomized controlled clinical trial. The study was deliberately designed to have two phases, again, this pre-market phase and a post-market phase. In the pre-market phase, patients were optimized on medical therapy and ultimately stabilized for at least a month prior to randomization into the medical arm or the Barostim or BAT plus medical management arm. At 6 months, multiple metrics were analyzed, including 6-minute hall walk, NYHA functional class, quality of life as defined by the Minnesota Living with Heart Failure score, NT-proBNP, and safety. The strength of the data using these metrics led to FDA approval in August of 2019, and ultimately 264 patients were included in this final pre-market analysis phase. And those patients were then followed on with time for the post-market analysis phase, looking at longer-term outcomes of cardiovascular mortality and heart failure morbidity. The key inclusion criteria for the BeAT-HF study are listed here. In particular, patients had a NYHA functional class of 3, and the LV ejection fraction was less than or equal to 35%. The BeAT-HF results in terms of symptom improvement were strong and consistent. Looking at exercise capacity here, and just to orient you on the chart, the far left is the BAT group in the dark blue, the middle in the light blue is the control group, and the lavender or purple is the difference between the two. So with 6-minute hall walk, we saw a net positive increase of 60 meters. This increase was statistically significant with a p-value of 0.01 and clinically significant as well. Looking at quality of life data, we saw a 14-point reduction in quality of life in the BAT arm. Notably, that reduction in the Minnesota Living with Heart Failure score is actually a positive, so a 14-point improvement in quality of life. This also was statistically significant with a p-value of less than 0.01 and clinically meaningful. And finally, with respect to NYHA functional class, 65% of the patients in the BAT arm improved at least one NYHA functional class. This compares to just 31% in the control group. This too was statistically significant. 94% of BAT patients improved in at least one of those metrics, and the authors defined a super responder rate in that patients responded either greater than 20% in the 6-minute walk or responded down to an NYHA functional class of 1 or improved by 10 points in the quality of life score, and 79% of patients met this super responder category. And finally, with respect to NT-proBNP, we saw a 25% reduction in NT-proBNP. This too was statistically significant at p-value of 0.004. So the strength of this pre-market 6-month data led to the FDA approval, and the post-market phase continued in order to assess long-term outcomes. And so I'll now discuss the post-market phase results. The following slides that we're going to walk through were presented again by Dr. Michael Zeil at THT just about a month ago. These data have not yet been peer-reviewed or published in a peer-reviewed medical journal. So I want to make that clear. So what I'm going to do is walk through these slides, either the same slides that Dr. Zeil presented in an abridged format, and I'm going to try to use some of the same verbiage to keep the messaging consistent. Access to the full presentation and symposium are available online. The slides that I'm going to show are summary slides. So on behalf of the Executive Steering Committee, the patients enrolled in the trial, and the study site personnel, it's my privilege to present the long-term outcomes of the BeAT-HF trial. BeAT-HF was a prospective, multi-center, randomized clinical trial, open label, blinded evaluation. Patients were randomized into two groups, those with the BAT and a non-implanted control group. The study eligibility criteria are listed here. The trial was performed in two phases, as we discussed, a pre-market phase with 264 patients, leading to FDA approval in August of 2019. In the post-market phase, the primary endpoint was a composite of cardiovascular mortality and heart failure morbidity, and the additional pre-specified endpoints are listed here. Using an intention to treat analysis, a total of 323 randomized patients experienced 332 primary events over 1,036 patient years of follow-up, with a median of 3.6 years per patient. The baseline characteristics were well balanced between the BAT and the control groups. Patient had characteristics typical of NYHA class 3 heart failure patients. And they had the expected level of comorbid diseases, including coronary artery disease, atrial fibrillation, and type 2 diabetes. Heart failure treatment at baseline was well balanced between the two groups and followed the guidelines in place at the time of randomization. Especially noteworthy is the high frequency of the highlighted treatments. This was a well-treated cohort. The primary endpoint, again, was cardiovascular mortality and heart failure morbidity, assessed using a negative binomial model. Cardiovascular mortality was defined as cardiovascular death, LVAD, or cardiac transplantation, and heart failure morbidity was defined as non-elective heart failure hospitalization and heart failure emergency room visit. The additional pre-specified endpoints are listed here. In particular, we looked at a hierarchical composite analysis using win ratio, which I'll spend some time on in the subsequent slides. In addition, all-cause mortality, durability of safety, and durability of our patient-centered symptom improvement outcomes. This slide shows a top-line summary of key evidence from the BeAT heart failure post-market phase. And I'll walk you from the top to the bottom. There's a lot to digest here. At the top, from the primary endpoint and the components of the primary endpoints were not statistically different between the BAT group and the control group. In the middle, importantly, both all-cause mortality and the hierarchical win ratio were improved in the BAT group. The hazard ratio for all-cause mortality was 0.66. This approached statistical significance with a nominal p-value of 0.054. The hierarchical win ratio was 1.26. This was statistically significant with a p-value of 0.04. And finally, long-term safety and long-term symptom improvement favored the BAT group. These improvements were statistically significant when compared to the control group, with nominal p-values of less than 0.01 across all time periods. So Dr. Zal and the steering committee came to the conclusion that the totality of evidence indicates that BAT is a safe, effective, and durable treatment for patients with heart failure with reduced ejection fraction. Now, the following slides were not included in Dr. Zal's presentation, but I've included them because I think it's worth spending a few minutes discussing the concept of a win ratio and the implications therein. So a traditional composite endpoint has some limitations in that all events are equally weighted. So mortality is actually weighted the same as a heart failure hospitalization. And in that, only patients who are actually experienced a heart failure mortality or a cardiovascular mortality or heart failure hospitalization would be included in the analysis building up to the primary endpoint. And this only represented 40% of patients in the BeAT-HF trial. In addition, the traditional composite endpoints do not include patient-centered metrics such as quality of life. So a win ratio analysis actually overcomes some of those limitations in that events are prioritized by severity. So a death is actually weighted more than a hospitalization. And it evaluates, by pairing all patients in one arm to all patients in the other, it evaluates the experience of 100% of patients in the study and allows for inclusion of quality of life metrics. So this slide is busy, but I'm going to walk through it because it's particularly important to understand where this win ratio of 1.26 comes from. So each Barostim patient, 163 patients on the left of the slide, is compared to each patient in the control group. And literally, you walk through this decision treatment paradigm to figure out who is the winner. And this actually results in 26,080 pairs, and that's just math, 163 times 160. And so with each pairing, you ask yourself first, did one patient survive longer than the other? If the answer is yes, that patient is the winner. And if the answer is no, you ask the next question. Did one patient avoid LVAD or transplant versus the other? If the answer is yes, that patient is the winner. If the answer is no, you move on to heart failure hospitalization. Did one patient have fewer hospitalizations than the other? The answer is yes, that patient is the winner. And if the answer is no, the last question is adjudicated regarding quality of life. Did one patient have better symptomatic outcomes than the other? If the answer is yes, that patient is the winner, and if the answer is no, that patient is deemed a tie. And so you take the total wins for the treatment group, in this case the BAT group, in the numerator, you take the total wins for the control group in the denominator, and you do the division, and in this case the division gives you a win ratio or hierarchical win ratio of 1.26 favoring Barostim. So you can actually say that there were 26% more wins in the Barostim group than there were in the treatment group. There are several studies recently that have used win ratio as a primary endpoint. Notably here is the TriLuminate trial, looking at the TriClip and severe tricuspid regurgitation. In addition, there are several studies that have reanalyzed their data looking back using a win ratio. Just a few are listed here, the Partners B trial for symptomatic aortic stenosis, EMPhASIS-HF, looking at eplerenone versus placebo in the heart failure space, and then the Paradigm trial looking with sacubitril valsartan versus enalapril. And it's important to note, you see win ratios listed here. We really should not compare one win ratio from one trial to another because the calculations are different. I use these for directional purposes only. So in summary, as we discussed, both the primary endpoint and the components of the primary endpoint were not statistically significant between the BAT group and the control group. That said, all-cause mortality and the hierarchical win ratio were improved in the BAT group. The hierarchical win ratio was 1.26, suggesting that the overall clinical benefit was 26% more likely in the BAT arm. And both long-term measures of safety and symptomatic improvement improved in the BAT group. Importantly, we saw the symptom improvement metrics at 6 months withstand the test of time. And so, based on the totality of evidence, I do think it's reasonable to come to the same conclusion as Dr. Zeil and the steering committee. The totality of evidence indicates that the BAT is a safe, effective, and durable treatment for patients with heart failure and reduced ejection fraction. Thank you.